a lot of ink and a lot of digital space has been taken up with the whole concept of readmission for heart failure. But it's not just heart failure. Readmissions are a problem for a variety of different patients. And we're here to talk about heart failure, but also as it applies to a variety of other things. I'm with Norine Walsh, MD, FACC, who is the director of the Heart Failure and Cardiac Transplantation Program from St. Vincent's in Indianapolis. This is a great topic for a variety of reasons, but let's start with the broad view. Why has readmission suddenly become such an important issue?
Well, it's actually an economic issue, and the reason that there's so much concern and focus on it right now has a lot to do with the penalties that are currently in place and will be in place for the next few years. So ever since the introduction of the penalty, hospitals that have a higher than predicted readmission rate for them will suffer penalties on all their Medicare reimbursement, with those penalties increasing from 2013 to higher in 2014 to higher yet again in 2015.
So it's a broad field of penalties, not just specific to a case.
Not specific to that case, no, it's all Medicare reimbursement. And the three diagnoses which are currently in the crosshairs are acute myocardial infarction, congestive heart failure, and pneumonia, with more to be added later. So although, of course, we've been worried about our heart failure patients' care for a long time, the focus on readmission is largely driven by the concern for the bottom line on the part of the hospitals.
So what were your tips? What pieces of advice did you have here in Las Vegas at the Cardiovascular Summit?
Well, you know, the evidence for how to reduce readmissions is scant. Single center studies, some meta-analyses. We've done a lot in the ACC with regard to our national program, Hospital to Home, to help people coalesce around best practices and to share their best practices. But the three things I focused on that do have an evidence base are early follow-up, and that's a follow-up appointment within 7 days, because there is some evidence, at least in billing data, that patients who are seen within 7 days are less likely to be readmitted. Secondly is patient education. There's been a lot of information, both single center studies and others, showing that patient education, as little as an hour of education delivered by a nurse to a patient before discharge, can impact that patient's readmission and other health outcomes. And then the third thing is disease management. So multidisciplinary disease management with nurses, doctors, pharmacists, the whole team putting their arms around that patient. There's a lot of evidence that disease management works.
There used to be a concern about getting the patient back to their original doctor. Mm-hmm. And what they found is that sometimes it took them 30 days to see their patient instead of 7. How do you control that gap when it's not in your control?
Well, I think the hospital is the place to start, and I think that the hospital helping all the doctors kind of work together so that everyone knows that if a patient's coming out of the hospital, they need that early follow-up, and whether that's done with a nurse practitioner who's knowledgeable in that disease process, such as heart failure, or a cardiologist, or an internal medicine physician. You know, everybody can be on the team. We just all have to be talking to each other and communicating so that whoever sees the patient at that 7-day mark knows what to tell the patient and what to look for a patient at risk.
You told a story about you get an occasional text from a doctor, maybe on a weekly basis. You know, why have you taken my patient away from me?
Yeah.
What do you do in a case like that, and how many doctors are there out there like that?
Yeah, there are some lone wolf doctors who like to provide all care to their patient, and it's interesting because some of these doctors are even subspecialists, like interventional cardiologists or electrophysiologists, and they may not have yet embraced the team focus, and so a referral out of a hospital stay for a kind of a critically ill patient to a nurse practitioner for maybe just a one-time visit seems anathema to them, but we kind of work on them one person at a time, but it's actually a mandate in our health system now, and so to some extent the lone wolf doctors are going to be fewer and farther between because it's just part of the care that we deliver to their patient.
Dr. Harlan Krumholtz has made a good point of the fact that so many people who are readmitted after a discharge of heart failure are readmitted for something way other than heart failure.
Right.
Talk about that for a moment and what that means in terms of the whole readmission process.
Yeah, so there's a lot of angst about this on the part of physicians who feel, and nurses who feel that they cannot impact this patient's readmission for a broken leg or something else. But I think Harlan makes some really good points about that period of time after hospital discharge being a time of frailty for that patient, and the patient needs to be evaluated on the part of all the health team for other issues that may drive those readmissions, whether something wasn't addressed in the hospital or not, because it is true that a common cause for readmission has nothing to do with volume overload or congestive heart failure. So we have to be aware of all the patient's need, not just our disease.
I mean, I've used the term, we have 50 shades of gray in America. Some people age gracefully, others not so much, and there's quite a wide spectrum. And so you have patients who have comorbidities that may be driving their readmission, correct?
Yes, because they may have COPD, they may have renal disease, and they may have they may have orthopedic issues, be unstable in that way. So part of our job in the hospital, we have to start thinking about readmission issues at the time of admission.
And not just for heart failure.
Right, some patients may need a different care setting. Maybe they can't live in their own home anymore because they don't have the skills to do so. So we really have to think very broadly. And I want to add also that by 2030, 20% of the United States population is going to be over 65. So as you talk about the shades of gray, this is going to be increasingly a big population health issue because over 65 is when most of heart failure happens.
I mean, most cardiologists are really good at acting locally and taking care of the cardiovascular system, but we now, I think, need to think globally about the patient.
Yeah, I think we have to think globally, and we also have to work with our health system, not just one patient at a time and one hospital at a time, but we have to be the science and medical champions of the hospital system to help the hospital with issues such as readmission.
I mean, the CV Summit has been the source of a tremendous amount of information, and you can read more about it at CardioSource World News. And here online, make sure you take a look at the various videos that we did here in Las Vegas. For CardioSource World News, I'm Executive Editor Rick McGuire.